WZTS-LD 16 Hinton, Cozy TV.
Doc Talk with Dr. Paul Conley is a production of TTV, which is solely responsible for the content.
Hello, I'm Dr. Paul Conley, and thanks for tuning in to another episode of Doc Talk. So we're going to talk a little bit tonight about cancer, but we're going to talk about how cancer is treated by different ways. My guest tonight is Dr. David Shimm. Dr. Shimm is a Harvard grad who went to medical school at Duke and then went to Mass General and has actually located to West Virginia and has been here for over 20 years. Dr. David Shimm is a specialist in radiation oncology. And, you know, Dr. Shimm, I really appreciate you coming on. You know, before the show, you had kind of talked about how you like to think about how we treat cancer in basically 3 different platforms. We think about if there's a solid tumor or a bulky tumor, then that's when the surgeon takes his scalpel to cut the tumor out or cut it away. We think about that there's medical ways to treat cancer, and that's when we think about the medical oncologist, and that's when we all think about things such as chemotherapy and now even immune therapy. But for you, you use x-rays, so you are a radiation oncologist. So maybe for the audience, you can explain what is exactly a radiation oncologist.
Okay, so a radiation oncologist is a physician who's been specifically trained in using radiation to treat cancer. And so I guess the first question is, how does that fit in with surgery and drug treatment? Well, first of all, pretty much every cancer patient has to have surgery because they need to have a biopsy. The surgery may be no more extensive than that, or it may be a radical surgical procedure to try to remove the entire cancer. One of the things that makes cancer is the fact that it doesn't like to stay put. It spreads to other parts of the body. And these can often be in locations that are remote from where the cancer started. For example, a lung cancer can spread to the brain, to bones, to liver. It can be hard to predict. That's where the medical oncologist comes in, treating with chemotherapy, treating with immunotherapy, and these drugs pretty much travel wherever in the body that the bloodstream takes it. However, the most likely place that a cancer is going to come back is going to be where it started. There can be things that limit the surgeon's ability to remove the cancer. There may be a nerve or a vessel or a bone that prevents the surgeon from getting a wide margin. That's where radiation comes in. And after surgery, radiation can be used to sterilize that specific area, not the entire body like chemotherapy does, but directed at a specific area. And of course, there are some patients who really do not require any surgery at all beyond the biopsy and are treated exclusively with chemo alone, with radiation alone, or with both together.
So, you know, let's walk back a little bit. Maybe you can explain to us, which I think is fascinating, that you can use x-rays to actually target. I think of it that you are basically laser focused with these x-rays and targeting a certain area. Where did radiation, maybe you can give us a little history lesson, maybe we'll walk back down memory lane. Where did radiation therapy originate, and how was that even thought about?
Well, there were 2 things sort of happening at the end of the 19th century. There was the discovery of radium, and also physicists were experimenting with cathode ray tubes. And these things were happening at pretty much the same time. And again, almost serendipitously, Marie Curie, who was working with radium, William Röntgen, who was working with x-rays, realized that radium or uranium and x-rays could actually expose photographic film without any visible light or any visible radiation. And it wasn't too long before somebody put their hand in front of a photographic film and shined an x-ray on it, and they could actually see the bones. That's pretty cool. And so the use of radiation for imaging came fairly early, but actually the first radiation was used to treat cancer probably within a year of the discovery of X-rays.
So at that point, what was basically being treated then? Was it mainly like solid organ cancers and things, as far as being able to pinpoint? Is that how that got started?
It pretty much started out with superficial things, skin tumors. They used radiation to make children lose their hair if they had lice infestations. But sort of the ability of an X-ray to treat something depends on its ability to penetrate deep into the body. And using radiation to treat deeper cancers depended on the development of more powerful X-ray sources. And that took a real jump after the Second World War, when some of the electronic knowledge that was used to generate radar waves was found to also be able to generate high energy X-rays.
So when we think about some of the cancers, I mean, you're just talking about looking at the hand, you're talking about the skin. So, we think about different solid organ tumors, but also skin cancer. So we know that skin cancer is one of the cancers that's actually on the rise. We are seeing more and more skin cancers. And we think about skin cancers as melanoma, that's the bad actor, and then non-melanoma skin cancers. Tell me a little bit about how radiation treatment and radiation oncology plays a role in treating these type of cancers.
Okay. Well, non-melanoma skin cancers are much more common than melanomas. They are not anywhere near as aggressive as melanomas, and often they can be removed fairly easily in the dermatologist's office. But if you have a skin cancer in a cosmetically sensitive area, eyelid, nose, this can often require fairly extensive reconstruction, and a cancer like that can be fairly easily treated with radiation. Radiation therapy really does not have a big role in treating melanomas. Typically it's used in somebody with an advanced melanoma where the cancer spread to the brain, to a bone, something like that.
So skin cancers that are non-melanoma, that's your basal cell, squamous cell, those are amenable. And I do know that I know some of my patients have actually been over here to see you here in Beckley, here in the Cancer Center, that had an area where maybe a plastic surgeon, was like, in order to get this on the face or what have you, you're going to have a scar. Even a plastic surgeon will tell you, if I want to take a scalpel to the skin, you're going to have a scar. But in your situation, you actually can radiate that squamous cell or what have you, and the scalpel is actually left in the drawer.
Pretty much.
So when you talk about radiation treatment, one, you're talking about where the cancer originated, whether it be a breast cancer, lung cancer, but then there's a term that you talked about as a spread. We use the word metastasis, metastasize, or
right.
Jumps, spreads. I tell people it's almost kind of like a dandelion, it originates here, and it gets into the lymphatics, the lymph nodes, and spreads. So you can use radiation therapy to not only treat the original or the primary site, but you can use radiation therapy to treat one of these lesions that has metastasized.
Right. So we often treat cancers that already have metastasized. So, for example, if you have somebody with a lung cancer and it spreads to a bone and causes pain or instability or neurologic problems, we can treat that. The other setting is what we call adjuvant treatment, where we're dealing with a cancer that we know is going to be a bad actor. It's very likely to spread. So in that setting, after the patient's had surgery, we treat the areas that the cancer is likely to have spread to. Cancer, the patient may not actually need the treatment, but with our current level of knowledge, we don't know whether this patient is cancer-free or not. So as a precaution, they get the adjuvant treatment.
One thing in my line of work, doing colonoscopies for colon cancer, certain colon cancers, you would do radiation treatment even prior, because I know we work together, myself, yourself, the colorectal specialist. We all work in tandem, and even though we work in different areas, we don't necessarily have tumor board, but we communicate. So there's some cancers that you would actually do, tell me if I'm wrong, radiation and maybe chemotherapy even prior to the surgeon doing the surgery, right?
That's correct. We do that a lot with rectal cancers. We know that certain rectal cancers that penetrate deeply or have lymph nodes are likely to recur in the pelvis. We learned years ago that giving radiation and chemo after surgery helped to reduce that. And as medical science progressed, we learned that actually giving the chemo and radiation before surgery could achieve the same benefit with less damage to the patient. And the final benefit of that is that sometimes you can end up with a less radical surgery. Nobody wants a colostomy, and if that can be avoided, that's a big bonus to the patient.
I know I've sent patients to you, and either one, it changes the surgery that the patient would have in the past had to have had. You know, we think about the APR, the colostomy bag, but there are some instances where I know in the hands of yourself, the radiation chemotherapy, that you can treat that cancer and the patient may not even require surgery.
That's correct. That does happen.
So we got about 2 minutes before our break. Palliative care. So now you have a patient that they're no longer going to be curative. That they have advanced disease and they have this bone pain. And, you know, we prescribe medically pain medications. We think about opiates, narcotics, benzodiazepines. Well, the problem with that is, you know, the patient, you know, causes dysphoria, they fall down, they get ataxia, mild constipation. How does radiation therapy help, or can it help with those patients that have bone pain?
It can help a great deal. It's probably one of the more common reasons that I treat patients. They have a painful bone metastasis. It could be in a long bone, could be in the pelvis, could be in the spine. And if somebody is taking opiates, not getting sufficient relief, or getting too many side effects from the opiates, that's something we can treat fairly quickly with radiation, often just a single treatment.
I know I've had patients in my practice who, unfortunately, they can't tolerate an opiate, either to gastrointestinal side effects, that they have nausea, like I said, they have constipation. You're really concerned that, you know, they're on an opiate, they get up in the middle of the night to go use the restroom, they fall down, then they have a hip fracture, what have you. And so, you know, I know that you have seen those patients, and literally with the radiation, it really alleviates their pain. So I just think, you know, when we think about radiation therapy, it's not only can be in some ways curative, but in many ways it's adjunctive to actually the surgery and chemotherapy, but also it can be palliative. Mm-hmm. So we're getting ready to take a commercial break. What I'm going to ask from Dr. Shimm here at the Beckley Cancer Center is we're actually going to go to where it all happens. Right. He's going to take us actually to where his machine is that gives the radiation, and we're going to actually see if maybe you can't lay me in the machine and slide me in there, and you can show the viewing audience exactly, you know, what you do here.
Okay. Look forward to it.
So I'm Dr. Conley. You're watching Doc Talk. We're getting ready to take a commercial break. Stay tuned, and we're going to be right back.
You're watching Doc Talk with Dr. Paul Conley on WZTS 16 Cozy TV. Stay with us. We'll be right back after these messages.
Vandalia Health is proud to be a West Virginia-owned healthcare system, bringing together the hospitals and providers of CAMC, Mon, and Davis. We are dedicated to enhancing the health of our communities through clinical excellence. Our compassion and commitment remain the same, with people you know and trust to care for you and your families. With more specialists, hospitals, and outpatient locations, we are delivering expertise and state-of-the-art care. Vandalia Health, expert care close to home.
Welcome back. Doc Talk with Dr. Paul Conley continues on WZTS 16 Cozy TV.
Hello, I'm Dr. Paul Conley, and welcome back to Doc Talk. I'm here with Dr. David Shimm. We are here live on location at the Beckley Cancer Center, and what we are talking about tonight is radiation oncology. Dr. Shimm has talked to us a little bit about where radiation oncology, how it got started, how it is used to treat certain cancers. We've talked about how you can treat skin cancer, solid organ tumors, and also can be used to treat such things as bone pain. So, Dr. Shimm, one of the things that we talk about head and neck cancers.
Right.
I know that we talked a little bit about how head and neck cancers, we're seeing that. Some people may not be aware that some of these tonsillar cancers actually are coming from HPV, which is a virus, and things that cause cancer are things that are inflammatory. So if you have an individual that has a head and neck cancer, we're talking a little bit about this mask here that you have individual.
Sure.
Maybe you can talk to us a little bit about what this actually is, and if you're a patient with a head and neck cancer, what is this used for?
Okay, so when we're treating cancers in the neck and the throat, we're trying to be very precise. We may be treating a cancer that's maybe just a few millimeters away from the spinal cord, a few millimeters away from salivary glands. And we want to make sure that we hit the tumor and at the same time protect the normal tissue. If a patient is coming in for 30, 35 daily treatments, we want them to be in exactly the same position each time we treat them. We don't want them to be moving around during the treatment. So to immobilize the patient, we make a mask like this. And this starts out as kind of a flat sheet of plastic. It's softened in a water bath. It's then pressed down over the patient's face, formed to their shoulders, their neck, their face, and within a couple of minutes it hardens. It attaches rigidly to the tabletop and holds the patient so they don't move. They can see through it, they can breathe through it, but it'll keep them steady enough that we can treat them to millimeter precision.
So this is really interesting. So this mask right here is actually the exact shape of an actual patient. So everyone gets their own shape and their own face.
Yes, and just it's made like this for each patient.
So that's really interesting. So you're right. So if you got something small, you're trying to hit the tonsil, you want to make sure that you're trying to target, and you want to be just laser focused, basically.
Right.
In your situation, X-ray focused to hit that. We were talking a bit about the break about some of the different cancers. That we men, we think about prostate cancer. We think about that if we live long enough, men are going to pretty much inevitably going to develop prostate cancer. And not all prostate cancer requires treatment, but those that do, radiation therapy is kind of one of the things that we think about.
That's right. Yeah, it's fairly commonly used for treating prostate cancer because to operate on the prostate, it's a pretty busy area. You've got the rectum right below, you've got the urethra going right through the middle of it, and a lot of men have difficulty with urination, having erections after prostate surgery. There are a lot of major blood vessels. A guy who's got a bad heart, who's on blood thinners, is going to have a hard time having prostate surgery. And radiation offers a way that we can treat people without running the risk of bleeding and with a much lower risk of bladder problems that they have after surgery.
I know when I started medical school in the early 90s, I would see some of these folks in clinic, and the radical prostatectomy is exactly what it means. It's radical and very barbaric.
Mm-hmm.
And these men that would have a radical prostatectomy, it really changed their life, not for the good. Like I said, they invariably had erectile dysfunction. They had issues with bladder control. But now with radiation, we can treat that without, again, going to the scalpel. I can also look in this machine here, the chemotherapy machine, and I know that there's more advances to come. And we talked also at the break that here this fall that you're going to have an additional machine. Now, you're hearing this background noise because the machine is currently on, and it's cool in here, but like Dr. Shimm said, this produces a lot of heat, and so this special room here, which also is lead, cement?
Concrete.
Concrete.
Feet of concrete.
So it's like a bomb shelter
Exactly.
in here to protect because of the radiation that goes on. But in saying that, radiation, I remember again when I started practice 25 years ago, we see radiation proctitis. That's where the rectum and the prostate, they basically live, they're neighbors. And you would see these males come in and they would have radiation proctitis, meaning they would be bleeding from the rectum. And you know what, Dr. Shimm? I really don't see that anymore. I used to get multiple referrals for men that were just having rectal bleeding. Tenesmus. Tenesmus means the sense that you have to go to the bathroom, but you can't, almost this rectal pain and pressure. So what has changed? Why are we not seeing this radiation proctitis? How has that improved so much?
Well, mostly it's the technology. The technology that was being used when you were in training, when I was in training, you can almost think of it as being like a plain film X-ray. This machine is more analogous to a CAT scanner where you can have much more detail, and whereas treating cancers with the old machines was pretty much on or off, here there's kind of gradations of gray. You can give a lot of radiation here, a little bit of radiation here, no radiation here, a lot of radiation here, instead of all or none. And that allows you to basically shape the radiation exposure around an organ that might otherwise be damaged by the radiation.
I think, you're talking about how x-rays and things, you're talking about the Second World War, and I think about, these bombing raids and how you would just literally just drop bombs and scatter bombs and just try to hit anything and everything. I think about now you have a Tomahawk missile that you can literally put it through the windshield of a vehicle. And I think about what you're doing here now is you're taking basically a Tomahawk missile and you're putting it right into the windshield, right?
Exactly.
Into the sweet spot where you're going to hit right there.
Exactly.
So I'm a patient and I come to you and maybe you can show us this machine and maybe you can show me what the patient does whenever they go into this machine.
Okay, so
I'll lay my head here.
lay your head here.
Feet go here.
Feet go there. Have you lay down. You can see this aperture here. It's kind of like a CAT scan. And we're gonna take you for a ride here.
I've never been on a ride like this before. Do I keep my arms and hands inside the ride? Yes? No?
You must be at least this tall to ride on this ride.
Well, you didn't measure me and you're taking me anyway.
Uh-huh.
Right into the machine.
And if you can zoom in here, you can see it's like a CAT scanner. It's enclosed, but it's really not claustrophobic. It's not like an MRI where you can stick out your tongue and touch the wall. There's room to breathe. You don't feel like you're trapped. Okay. And a typical treatment would last anywhere from a couple of minutes to maybe 20 minutes for some patients. Patients are monitored continuously. We have closed circuit TV. We have microphones so patients can talk to us. We can talk to them during treatment. And then at the conclusion of the treatment, the patient is then taken out of the machine.
So, Dr. Shimm, as I'm laying here in the machine, you actually are scanning my body to see where you're going to actually fire or basically use the x-rays, and this is all seen in a camera?
It's more like it's basically a program. That program has already been set up, and then sort of as you are slowly advanced into the machine, the inner workings of this machine kind of go around. So it basically almost describes a spiral in your body. around and around as you go in. And the intensity and the direction is pre-programmed. It knows where you are. And it's on, off, on, off, on, off. And that way it can radiate here, stop here, radiate here, stop here, radiate. And basically you can deliver radiation in a fairly complex pattern that treats certain areas more intensely, other areas less intensely, and can completely shield other organs.
Now, I know we had talked about, with all the advances in technology, this machine compared to the machine that is getting ready to come here just this fall, what is the advantages with the newer technology? Where are we going with this?
Newer technology, it's faster and offers us some additional functionality that we don't have here. For example, the new machine is going to have electrons, which are very useful for treating fairly superficial tumors. They don't penetrate very deep. This machine only does x-rays, so we wouldn't treat a skin cancer on this machine. We have a small machine in the other room we can treat skin cancers with, but at best it can treat something maybe about the size of my hand. Occasionally we'll have people with fairly extensive skin cancers that may occupy the side of their chest, like a breast cancer occurs. Those can be treated fairly easily with electrons.
That's amazing. You ready to take me out?
If you want.
Yeah, this is really interesting. I feel I'm talking my age. I feel like the Incredible Hulk with David Banner and gamma radiation. I feel like I'm being wheeled into like the machine like that.
Yeah, be careful of any cockroaches you see in here, because they're exposed to radiation all the time.
Well, this is not at all scary at all. Well, I just think that the technology and everything that has, get my microphone, as the technology has continued to, improve, it just amazes me, Dr. Shimm, that what you're doing right here in Beckley, West Virginia, being able to treat these cancers, being able to help people with palliative care, being able to treat head and neck cancers in such a way that the things that we just didn't have before. When you're talking about skin cancer, I have patients, just to your point, that will have multiple skin cancers where they're maybe undergoing treatment for Crohn's disease, and some of these anti-TNF inhibitors increase the risk of skin cancers, and sometimes these people have multiple skin cancers, and you're talking about on the face. So if you have multiple skin cancers on the face, you really don't want to have your face, surgerized with all the multiple scars. And this is a type, your new machine, you're saying you could get in a machine like this and it would be able to treat all those at one time.
Right. But it's kind of interesting to stand back and think that here in Beckley, West Virginia, we can do the sorts of treatments that there's no way we would ever have dreamed of when I was a resident back in Boston and Harvard. I mean, night and day. We can do so much more here now than we could do at basically the best places way back when.
Well, Dr. Shimm, I really, really appreciate you. We're getting ready to run out of time, and as always, the show just flies by so fast. But I really appreciate coming here. We're with Dr. David Shimm here at the Beckley Cancer Center, and we've been talking about radiation oncology. I'm Dr. Paul Conley, host of Doc Talk, and until next time, you have a good night.
Vandalia Health is proud to be a West Virginia-owned healthcare system, bringing together the hospitals and providers of CAMC, Mon, and Davis. We are dedicated to enhancing the health of our communities through clinical excellence. Our compassion and commitment remain the same, with people you know and trust to care for you and your families. With more specialists, hospitals, and outpatient locations, we're delivering expertise and state-of-the-art care. Vandalia Health, expert care close to home.